To introduce our speaker for tonight, an orthopaedic surgeon from the Department of Surgery, Orthopaedic Surgery, Mr. Fraser Harrold, and he's kindly going to talk about the assessment of diabetic foot ulcers. So welcome.
Thank you.
Fraser.
Everyone hear me? Microphone working? I used to work in a department with a professor of anatomy. He's a big Canadian, and he used to boom out. Am I audible in their ear? Not around. So everyone can hear me clearly? Good. Welcome. This is really a talk and a bit of a journey with some of the research that I'm doing in the department. I'm a orthopedic surgeon. My interest is in foot and ankle, and I have an interest in diabetic feet. And I came here, and my colleagues were very happy to see me scoop it up and carry on the work that I was doing based in Scotland. So this is a talk about the journey of that. So who am I in a traditional New Zealand way? My mountain is the Cairngorms in the heart of Scotland, the Highlands. You can see the top left there, that's my family and the dogs on a summer's day, up on the top of the hill. It's still got the recording for the highest wind speeds in the UK from there, just over 200 miles an hour. So it's pretty breezy all the time, but that would be my mountain. My river, River Tay. So that's where I lived on the east coast of Scotland in Dundee, and that was our view from the house. Biggest river in Scotland, the largest catchment in the UK in terms of water. And then my clan, although my accent doesn't say it, I'm Scottish heritage, and my family are from the west coast of Scotland, MacLeod family. And my kids are wearing the kilt there. Incredibly, they wear the kilt more often here than they did in Scotland. So, which I find amusing, and they play their bagpipes more than they ever played in Scotland. So it's we didn't appreciate how much Scottish passion or how much Scottish heritage there is here when we first arrived. And of course, my name, you know. So there are two strands to the talk. It's really a bit sort of research journey, and also some of the challenges that I've experienced in this area of work. So I've been keen on looking at an early warning system for diabetes, for diabetic foot, for a long time. And I've had it in my head probably a decade. And I'll talk through some of where it originally came from. And then I've been pushing for service provision, and I want to talk to you a little bit about what we've done in New Zealand and try to change. But I thought before that, and there's a little bit I put in brackets, there's a bit I'm not going to talk about because that's something that's also ongoing. It's a third strand. But I thought I'd give a bit of background because this is the history of medicine. I have to thank this group because everybody is involved, and that's a big thing about research. You have to collaborate. It's so important. You can't work in isolation, and there are some really big groups here in Dunedin that are heavily involved. And I particularly like to thank Health Research South, and also the charitable trust, the Otago Southland Diabetes Research Trust, who have sponsored a lot of the work. And I see Chai, one of our summer students, she was sponsored by the group to do some of this work. So definitions, I'll let you read the definition. I'm glad there are no endocrinologists that I can see maybe. Anyway, it comes from the two words, the Greek and Latin. So the Greek word diabein is really to pass through, and diabetes is the siphon, this passing through of vast quantities of urine. And then the Latin bit is to do with sweetness. So mellitus is sweet, and that's where the term came from. And then the combination comes later on, and I'll go through that. But it's been known for a long time. 1500 BC, some of the Eda papyrus reports on the passing of or emptying of urine in this disease. And certainly the Indians and Chinese and even Japanese spoke of the taste of urine, and they noticed that in the previous picture of the dog licking urine, well, they had noticed that dogs would lick some urine more than others, and that was one of the things where they picked up that the urine was sweet. And obviously the Romans mentioned the diarrhea of urine, but it was John Roller, one of the urine tasters, who first coined the phrase diabetes mellitus, And that's where the term originally came from. But it's I don't think it's a dying art, that I suspect. But that's where it comes from. Do anybody know those two characters there, the picture? Anybody recognize that? I'm sure I taught some students who should have remembered. So that's part of the diabetes history. Frederick Banting, the guy on the right, was an orthopedic surgeon. And he had an idea, an experiment that he wanted to try. And he approached John McLeod, who was professor of physiology in Toronto University, and asked if he could do this work on just isolating the outflow from pancreatic islets from dogs. And he wanted to see if he could affect glucose control. McLeod liked the idea, and he handed him over his medical students, Charles Best, for the summer. And in May 2021, they put to work in the lab and managed to isolate insulin from, which they called islets, from a dog, and then created a diabetic model. And then they injected the insulin back into the dog and managed to drop the glucose levels in the dog. And so that was really the first case where they'd managed to do it. But that, of course, that's in isolation. And what they couldn't do is do it in humans. But they did manage to get Collop, who was a biochemist, involved. And he managed to mass produce it in sufficiently enough to put it into a 14-year-old kid. And he got an abscess from the injection, but it did drop his glucose levels. So that was really the first trial of insulin. To their credit, these guys had the patent for it, but they sold the patent to Toronto University for $1. So they ensured that it was never going to be sold for money. Remarkably, 2 years later, which is really incredibly short for the Nobel Prize, they got their Nobel Prize. But it was only given to Banting and McLeod. The medical student didn't get it, and nor did the chemist who had produced it. But of course, the history is really interesting to know. So I would encourage you to read the history of this particular story, because there are lots of other people involved, and you would probably reflect nowadays it may take a decade for someone to get a Nobel Prize for the work, because you have to get the bigger picture. And there is a bigger picture. There was a guy called Paulescu who did exactly the same thing, but because of World War I, was interrupted in the middle of his experiments. So he never actually got the data out in time. Of course, history is littered with these. So the famous group are these from Toronto. This is a slide actually that I took straight out of my university lectures that I give to fifth-year medical students, because I say this is your epidemic. This is going to be your issue to manage. Prevalence has increased from 3 to 5% in just under a decade. That was in 2005. And at the moment, 8.3% of the population have diabetes. It's absolutely massive. It's now the leading cause of neuropathic foot. Syphilis used to be one of the main causes. Now it's not. And at the moment, it's 80% of non-traumatic amputations are the result of diabetes worldwide. It's enormous. If you have an amputation, there's a 10% chance you don't leave hospital. And 50% of those patients will have an amputation on the other side within 3 years. And potentially 3/4 are dead in 5. So it is a devastating condition. I just screenshotted it. This is from the New Zealand data just in October last year. So that's the trajectory of diabetes in the last 10 years. So it's absolutely going up. And you can see there are regional variations. And you look at the Northland and Auckland. The yellow line is us at the bottom, but it's still rising. But I would argue it's not quite exponential, but it's not far off for some regions. Many of you will know Sir Jim Mann, who is a professor in this university. he had a big part to play in this project. Initially, the Medical Research Council in New Zealand pushed in the 80s to try and get some consolidation of thoughts and thought process into management of what they thought would be a pretty serious condition. And in 2001, PwC were commissioned to report on the state of diabetes and the potential, having a little bit of vision to see how it would end up between then and 2040. And they've met in 2001, 2008, and some report in 2017. I'm going to show you some of the data that they looked at. Where are we at now? Well, this is 2001. Sorry, this is 2021. This data was published. 6.3%, I think it is, currently in New Zealand. The rate. We're not the worst, but we're not the best either. We know it's associated with obesity, and currently New Zealand is the third most obese country in the world. So that's that should be an alarm bell. In addition to that, you've got this inequity that we know exists, and based on the projections, is only going to get worse with this disease. So it's a challenging position for us to be in. So Jim Mann and the group were asked to look at what things they could do to make it to intervene and improve the outcomes for patients. And there were 4 strands to their work. One was looking at just healthy lives and eating and exercise. But the area I'm going to speak about, and the one that has interested me for a long time, is foot screening and foot protection, diabetic foot, because we know it's a big part. And the cost savings they anticipated, if we got this right, were between $36,000 to $40,000 a year per amputation, with a reduction of around 600 amputations per year by intervening. So one of the complications of diabetic foot is diabetic foot ulcers. This is the commonest pathology. Incidents are up to just over 5%, up to 6.3%. However, the prevalence is probably close to 10%, with a risk of up to 1/3 of patients with diabetes getting a diabetic foot ulcer. Once you've got one, there's a pretty good chance you'll get a recurrence of that ulcer within the year, and 60% will get one within 2 years. And of course, once you've got that, your risk of amputation suddenly changes. You've suddenly got a 15 to 30% chance of ending up with an amputation if you have a diabetic foot ulcer. And I've already mentioned about the amputation rates. Once you've got one, every chance you'll get another one on the other side, and the mortality I've spoken about already. Little example here. So this is a gentleman, I got a call from the vascular surgeon on a Friday afternoon doing his clinic in Oamaru. He's based here. And he'd seen a 36-year-old male who'd knocked his foot about 4 weeks ago, seen the GP about it twice. He'd had a previous toe amputation under the vascular team. That was his x-ray taken at the time. For those who are not used to looking at them, that's pretty much a normal looking x-ray. But he had a swollen, painful foot, and he was still troubled with it, troubled enough to go twice. When the vascular surgeon saw him, that was his foot. That was just a few weeks later. That's a month. So he's got an ulcer on the medial side of his foot, and those not used to looking at it, you can see that the midfoot, the forefoot, has disengaged from the hindfoot. So he's completely separated. This is a rare condition called Charcot, but it's part of the diabetic foot ulcer group. Normally, they look like that. Swollen, hot foot, often treated for cellulitis. But if it's Charcot, the primary treatment is contact casting. So that is the gold standard for treating Charcot. And all we do is hold it all together while this condition burns itself out. Normally takes 7 to 8 months to do so. It can vary. What we try to avoid, and I put it in a small picture, is this. And I desperately hate operating on these patients. For this gentleman, though, he ended up I had to take him to theatre the same day and operate on, debride him, temporarily stabilizing with wires rather than anything more because of infection. And unfortunately, at 2 months, he was still like that, unchanged. So it was worse. And you can see the wires have backed out. And so the result is that. Thankfully, he's in his 30s, so he's likely to do well with that, but it's a devastating end. And based on the data you've already seen, he's got a reasonable chance that his other limb will end up the same way. So it's not a great outcome, but it really reflects this. So this is the amputation rate across New Zealand. And this is only data for those who are referred for prosthetics. Anybody who's too obese, too old, and unlikely to manage with a prosthesis will not be referred to that group. And they'll be put into nursing homes, rest homes around the country. So they're not part of this data set. The instances, this paper down here was published just recently, last year, slightly higher rate of amputations, but that didn't include the trauma ones. So these are big numbers, and are getting worse. So based on this problem, we need to find a framework in which to work. And this was a review of literature that was done looking at modifiable interventions that would improve outcomes for patients in terms of the development of diabetic foot ulcers. It was published in the BMJ in 2017. And they came up with 3 really important things: early recognition, prompt referral to a multidisciplinary service, and early intervention. So what's the current surveillance here in New Zealand? It's pretty good. It's a really good model that was developed, and this was part of that group of 4 interventions that they were trying to work on. It was an annual check of feet, at least annually, and if those patients were at risk, it would be more than that, twice annually, or to a diabetic foot clinic. But part of the check included HbA1c, looking at your blood pressure, lipid profile, kidney function, retinal checks, and that was to be every couple of years. But the important thing was checking peripheral circulation and sensation in feet. So this gets me back to my original story and what I wanted to do. So I'd read this a long time ago. Eye-foot syndrome. This was a paper published in The Lancet almost today, 50 years ago. And Malins, John Melville Malins, who actually, Sir Jim Mann was a registrar working for him in Birmingham at the time. So there's a little bit of a link there, and he knew him. Published this work on a group of patients. I'm going to read it because it's I had it on the report. I just want to read what he said because it's quite insightful. Apologies, the thing is not working. I hope I've put it in here. No, I didn't. I missed it. I didn't print it. Sorry. The essence of it was he picked up a group of about 50 patients, male, he said, that had presented to his clinic with advanced diabetic retinopathy and severe ulceration of their feet. And he said, unusually, he said, they didn't seem to care. And of course, we recognize that. I call that diabetic brain because their brain is full of sugar. They just can't comprehend what they've got. But he said half of those patients were dead within the decade that he had seen them. And they had this relationship, and he called it eye-foot syndrome. And so he recognized this as a potential pathway. And so I was interested in this since I recognize that retinal imaging is quite an important part of diabetic screening. And this paper was published, I think it was 2017, and this was a pickup on incidence of diabetic neuropathy with optical coherence tomography. Now, this is the technique that's commonly used. You'll see it in a lot of the optometrists will have this technique for eye imaging. And I'd already seen optical coherence tomography before, and it was actually a description I'd seen at MIT and Harvard have been using it to look at blood flow in neonates. And I thought it was a brilliant idea, and I thought this would be a great thing to use on diabetic feet to look at blood flow. So kind of it all pulled together. So I was interested in it. And at the same time, of course, you know that if you're thinking about it, somebody else is doing the same thing. And so this was also published looking at diabetic retinopathy and diabetic foot ulcers. And they recognize this relationship. But this was all done from a perspective of eye disease and seeing the diabetic foot. So they recognize that they ought to be checks for both at the same time. This was a paper from 2021. So I'm going to take you on a little detour now, because this was the detour I took. So I was interested in optical coherence tomography, and by chance, this university has one. There are only two in New Zealand. The other one's in Auckland. And so I managed to get hold of Azam Ali in biomedical engineering, and to see if I could use it. It's a pretty cool tool. They use a high resolution, effectively a diode that uses light and splits light off. One bit goes to the mirror, the other bit goes to the tissue involved, and then you look at the difference through what we call Fourier transforms, so basically mathematical algorithms. And it allows you to look at even 5-micron level, you can look at flow. And it's because it's temporal, you can look at it effectively 3-dimensionally as well as through time. So you can look at change in blood flow through time. So you can look at basically angiography. A part of it also will allow you to look at the structural mechanics of it. And this example here on the bottom right is of a diabetic retinopathy, where the arrows show the thickening of the retina associated with retinopathy. So I took that detour based on this and spent a long time, probably 6-8 months, working on this, trying to do what was done here. Again, somebody else is doing the same thing because you're thinking about it. This was Western Australia. They published this work looking at optical coherence tomography for imaging diabetic feet. And the model they used was to look at 13 normals, 13 who had neuropathy, and 13 who were just ordinary diabetics. And they screened them and looked at them over a 30-minute period, but changed the temperature of the foot. So they were looking for change in blood flow for these 3 groups. And what they picked up, what they noted, was that the normals had much higher blood flow when the temperature went up, which you'd expect to see. And those who had neuropathy had much lower blood flow than the other 2 groups. And so we tried to do this here. But in fact, we've never been able to replicate the experiments they had because the data is not objective. It doesn't punch out numbers, it punches out images. And it was too sensitive. So even subtle changes, we tried it on normal people, but if they ran up the stairs, it was going to be different. If the temperature, ambient temperature or humidity in the room changed, the results were different. And so it's almost too sensitive. And so this little project that's taken quite a long time, and I was hoping I would integrate into a screening model for diabetic patients with diabetic feet in, for example, an ophthalmology department, we've had to abandon. There may be other things come through, but that was always the ambition. So that's my little detour. I'll come back on. So the next thing we did, we got Chai here as a summer student to help, was, well, if I can't do it prospectively like that, why don't I look retrospectively? And so the plan was to go back through the database and look at all the eye imaging of diabetic patients and look and see where they appeared in the diabetic foot clinic and see if we could correlate their disease and when their diabetic foot disease arrived, in the hope that we could pick up from a retinal scan to say, well, in the next 2 or 3 months or 6 months, you're likely to get diabetic foot disease based on your eye imaging. Well, it's quite tricky, as Chai has found out. Lots of people are involved. We got data from Well South. They happen to be reviewing Southern's data on diabetes and how accurate they were. And so we got involved with that, and we managed to put their data, which is the GP data, with our own as hospital data to try and identify it. And John Sholem, the renal physician, had also picked up, he'd got 50 patients that had turned up in his practice with end-stage renal failure, who were diabetics, who had never been picked up. So the disease process that we'd never identified. And so he wanted to include that as part of the group. And so we looked at that. But it's chaos. This is just EGFR. This is just one example. But what you see, other than the general pattern, is missing data. It's just tons of noise in all the data. So the Well South data is incomplete. And I don't think we appreciated, we've learned as we've gone along, that's HbA1c, for example, that eye checks are done by all these different groups, and none of them are required to report back the assessment of the eye disease. Some will just report blandly what it was, but most don't have to. In Australia, you're obliged. If you assess diabetic patients, they are obliged to feed that data back into the medical database. So they report it, but not here. And believe it or not, after the review that Well South did, they found that less than 50% of their patients are getting screening, despite that report that came out 20 years ago, 20 plus years ago. So that's meant it's been really difficult to solve. Currently, what we have done, we found out there's a cohort that gets seen in the hospital. We've got about 160 of them. And so we're going through their data because it is reported accurately and they have classified their retinopathy. And we're going back trying to match up when they turn up in the diabetic foot clinic. So that's the ongoing work that I've got a PhD student who's doing some extra work for. So I'll feed it back on that at some stage. But the hope is that we can find this link that was found 50 years ago. So the next bit I briefly want to speak about is the referral, prompt referral to a multidisciplinary team. So I came here and I was really impressed with Dunedin. They've got a fantastic service. They've got a really cohesive group. It's pretty complete, and they pick up all comers in terms of the diabetic patients. We know this already. This is NICE guidelines, the UK guidelines from 2015. We recognize that if you have these specialists involved in diabetic foot care, your amputation rates go down and your outcomes for your patients are better. It's a big group of people. You've got diabetologists, podiatrists, specialist nurses, orthopedic surgeons, as well as vascular surgeons are important. If you are a big group, then interventional radiology. I haven't included microbiology in there. That's another important group that should be involved. And obviously those with the skills in managing wounds and managing casting, because as I said to you, contact casting is the gold standard. It's gold standard for all diabetic ulcers and their management, non-operative management. A team has to be able to move very quickly and flexibly. You should be able to admit patients within 24 hours. We have just moved our clinic from a Friday afternoon to a Wednesday afternoon to allow us to do that, because Friday's a shocker. You bring them in on a Friday and by Monday they're moribund because you've left them to an on-call team and not to the team that generally look after diabetic patients. So that's a positive move here. Under a named consultant, so we do that. The patients go to 4C and they are admitted, but we all have input into that patient, so they're under the care of one consultant. And obviously we can get early referral. We have a very good diabetic MDM, which is a diabetic meeting that we hold every Thursday afternoon. And we discuss every patient across the South who have been referred by whoever it is across the community, and escalate if we need to. So we decided to do the same and look at New Zealand and see what the provision of service was. And so Nira Kumar, who was one of our registrars, did the work. And Jane Terry, who's a research fellow we've managed to find the money for, and she's been fantastic in just getting a lot of this grunt work done, got involved. And we presented this work at the New Zealand Foot and Ankle meeting. It was a questionnaire. You don't need to look at the detail. I'll go through the results of it, but it's a questionnaire that we put out looking at the provision of service across New Zealand. We got a pretty good response with 60-odd respondents across multiple specialties. We sent it out to everybody. It's probably not as many as we'd like, but still not bad. And it covered all the 17, certainly the 13 regional hospitals, but from 17 hospitals, we got responses. Frequency of clinics. Most had clinics on a weekly basis, the majority, but some were fortnightly, some were monthly, some didn't know. But it was present in the major hospitals in New Zealand, which was important. How many had a diabetic MDM? Only one hospital had it twice weekly, but the majority had a weekly diabetic MDM, which is really good. But that was 9 hospitals. 9 of your major 13 hospitals had a regular meeting about diabetic foot patients. What about their early review diabetic foot clinic? Well, the majority said they could. They could see a patient acutely through the diabetic foot clinic. But 13, so that's a third, couldn't do that. And the majority would do it within a week, but there were some 2 to 4 weeks and some 1 to 3 months. As you know, that's too long with this condition. Admin is really important. It's really difficult to run a service if you don't have administrators. A third of them don't have administration to run a diabetic service. Now, what about this important area, this diabetic contact casting? This is a really fundamental part of non-operative management. More didn't have it in their practice than did. And yet it's a cornerstone of diabetic care. So it doesn't exist. Here's the staffing. This is really interesting. So I thought I'd start with us and Christchurch. Actually, we're really good. It's quite difficult to get your head around these little spider diagrams, but this effectively the ring are different specialties. And so what you're looking for is the spokes of a wheel. And if the more spokes you have, the more coverage you have in terms of service, in terms of the specialist cover. You can see ours on the left-hand side. Interestingly enough, we don't actually have an endocrinologist anymore in our clinic, just for pressure of service. So we have a diabetic nurse involved in the care of diabetic patients. Christchurch is probably better suited, and they have pretty good coverage across all the specialties. That's North Shore. It's quite a big hospital, isn't it? So they don't do diabetes. They don't feel they can do it, so they've left it. One podiatrist, well, it's not one podiatrist, there's many podiatrists, but only the podiatrists are involved in diabetic care at North Shore. Waikato is fantastic. Really good group, really engaging group. And actually they do contact casting, and I'm hoping they're going to get involved with teaching contact casting. Auckland City, patchy. Whangarei, really poor, isn't it? Really poor. That will reflect badly in the outcomes. And here, this is Tauranga and Hawke's Bay. No involvement of orthopedic surgeon or vascular surgeon, which I would regard as important cornerstones of care. So that's sort of a snapshot, except this is people's perception of what they think it is. It may not be the truth. So this is as people understand it. And so we probably have to go to each unit across the country and actually check and verify this before we commit to talking about it more seriously. But anyway, it's a little snapshot that we presented. I've already shown you this thing about the amputations across the regions. So that is definitely going up. I actually organized a meeting in Auckland in December to try and engage the orthopedic surgeons. So that was a kind of webinar that we linked up with Australia. And it's really a push from an orthopedic side of practice to try and get more orthopedic surgeons involved in the care of diabetic patients. And I think we need to do that across other specialties too. The last bit I'm just going to touch on early intervention. So the only thing that we are trying to do is we are trying to teach people to put on contact casts. We have one person, Brent, who's our orthotist in this city, who's away on holiday for 5 weeks. We haven't put a contact cast on for 5 weeks, and I've had to take ones off patients and manage them in boots until he returns. So that's something that we're trying to address. So we've actually sent a nurse over, Anna Doherty, who's one of our senior nurses here. She's been in the UK for 6 weeks on a casting course, a technician's course. The UK they run their service by having professional technicians that just do casting. That's their only job. And so she's now the only trained one in New Zealand. And the plan is to try and spread that out and get people across, certainly across at the moment, the southern region, and then eventually push that out to nationally to try and get consistency with contact casting. So that's our journey. And in that time, the diabetes is going up and the pressure is on our service. I've actually just picked up the data. Kathy just gave it to me today. I asked her, so how many patients are we being referred now to the diabetic foot clinic? 2022, we had 350 patients. 2023, 430. 2024, 498, 500. So it's gone up 50% in 2 years. And it'll be much higher this year. And the majority for us are coming from Invercargill. So the picture's getting worse. The management is clearly mixed across the country. One of the hard things that we've experienced is putting that data together, be able to actually look at data properly, because they're across multiple platforms. It is all there, but we just can't get it together. And then the last thing I mentioned to you was the challenge of staffing and running a clinic. Most of the clinic we have is not funded. So it's done because we need to do it. Thank you for your time. I think it's part of the same picture, isn't it? So yeah, thank you for listening. Any questions? Not a cheery.
I've got one. Back to the optical coherence tomography thing. What tissue are you actually looking at? It looked to me as though you were looking at a retina, and to me, ignorant of it, it looked like retinal detachment. But were you looking at blood vessels themselves, or the retina?
That was a foot. That's the surface of a foot.
The skin.
Skin.
Oh, I see.
So to tell you blood flow in the very superficial layer of the skin, even down to almost down to subdermal, almost, but not quite.
I see.
So it's to do with blood flow.
Right.
So that's what we were.
And what does the machine look like? I mean, is it an ultrasound machine? Ultrasound?
It looks like the old Mac tube. Remember the colored Mac, multicolored Macs?
Yes.
So it looks like that. It's
Right.
very small, very compact. If you go to Specsavers and you get your eyes checked, they will check using an OCT machine. So it's in every ophthalmology department, well, certainly the ophthalmology department, but every optometrist you'll find they have an OCT machine.
Oh,
And when I first looked at it, you couldn't find one for love nor money. So there are only 2 research ones in New Zealand.
oh.
I still think it's a great answer, and my feeling is if you go to your optometrist, you should get your feet checked too.
Yes.
That's how I think it should be done.
Another question as well. On your second or third slide, you had incidents of diabetic disease in various countries. The US was not on there. I didn't see the US.
I've taken it off since Trump came in. No, I don't know.
I mean,
I don't know actually.
I imagine
I
that
didn't
the US would be way up there, because it's the third slide or so. Further back. There they are. I was looking for the US there. Oh, it's the fourth one, yes. Missed it. Other questions?
Thank you for an interesting talk. I've got 2 questions. To what is the epidemic most attributable? And how much value is looking at peripheral autonomic nerve function as an indicator? This place is famous for the wrinkle test, of course.
the two questions. The one, probably the link that I think is recognized most is obesity as part of it. And I suspect that's also linked both to nutrition and probably activity, level of activity. But I don't think there's anything beyond that. I have to have an endocrinologist back me up on that, but obesity is one of the key markers of it. In terms of the test, or what value or
any guide to microcirculation?
Almost certainly it correlates, almost certainly, because we know it's a systemic condition, a multi-organ condition. So beyond that, I'm not sure I can answer your question.
Yes.
Thanks for the compliment you on your slides. It was so nice and clear. Two questions. Firstly, how effective are weight reduction programs in minimizing or decreasing the complications in the foot?
Well, only in the sense that we know it can reverse pre-diabetic patients. So that has not been, I don't think that has been studied as far as I'm aware. And that's a part of the wider picture of data mining, is to be able to look at these patients in an objective way. And I don't think there's anywhere in the world currently where we can actually see whether pre-diabetic patients who are reversed have any of the long-term complications that diabetics who develop long-term diabetes and sequelae of that. I don't know of any data on that. You are perfectly right to say, actually, I'm looking at the wrong end of the problem. As far as my perspective on it is, until the clever guy sorted out and cure diabetes, we are going to have these problems. So we have to find a way to manage these problems early. And for me, it's about an early warning system. Once we get the cure for diabetes, I'll be happily out of work in terms of doing my diabetic clinics. I'll be delighted to do that.
I could add, if only you were right, that you're at the wrong end of the problem, but you're faced with reality. The other question is, you mentioned quite correctly that the patent for insulin was sold for $1. And yet we hear that the cost of insulin in the States is quite ridiculously high. It seems that the previous government managed to get that down to about $8 or $10 for the prescription. But now with Trump back in again, he's withdrawn that subsidy and it's gone back into the $80, etc. So it seems that that old ethic has gone. Well, we know that. But what's it going to do to that graft in the USA?
I don't know. So that's an interesting part of the story, because there's more to that insulin story. Because obviously it had to be artificially made. So the insulin we have today is not the same insulin that they first pioneered and manufactured. The artificial one, of course, was patented. I think it's Nordisk. I think the Norwegian company, were the ones who developed the synthetic insulin. And so that's the one that everybody used worldwide. And of course, that is patented. So they just mimic the proteins that are naturally there. So again, that's out with my skill set to understand that. But I think that's why it is expensive. And I suspect you're right. It's going to have a big impact on outcomes for patients.
Thanks, Fraser. It's been a really interesting talk. I was just interested in the foot casting and how that helps manage the diabetic foot disease.
It's a very simple principle. The cast is put on in a very consistent way around the whole foot and lower leg. And what it does is distribute load across the foot evenly. You can offload the areas where the ulcer is sitting by just using simple dressings, and load the rest of the foot, because we know that patients always walk on them. So you've got to create a system there where they can load the foot, but even the pressure across the whole of the foot, avoiding the ulcerated area. So it's difficult to do, and it's not without complications. I've got 1 or 2 patients who have had amputations because of the cast. You get pressure areas that's not put on properly. Very old fashioned, but it works very well.
Other questions?
May I ask a social science question? One of your slides, maybe just soon after the set, talked about the difference of incidence in the regions within New Zealand. And I'm interested to know what factors you would like to tell us are responsible for the north part of our country being exponential
Yes.
as opposed to southern, a slightly gentler incline in
beginning.
incidence.
Yeah, so I think it's right at the beginning. I'll just get it up. I suspect it's a combination of factors. One is to do with the distribution of ethnicity. So we have relatively few Maori and Pacific Islanders down here. And we know the incidence of diabetes is much higher in those groups. And the population, the proportion of the population of Maori and Pacific is much higher in the north. The second thing is, I think they're poorly, there's poor medical cover, and I think that's reflected in the little audit we did of practice across New Zealand, where basically I know Whangarei that, I mean, it's absent. There is no MDM, there's no clinic. I actually met at a meeting and they asked if I wanted to go up and do some locum work, just to do some diabetic locum work. They're absolutely desperate for staff up there. So I think that's the second bit. And I think the third is education, which is part of the model that Sir Jim Mann put in there, is teaching people about the importance of living well, eating well, and educating people about foot care, eye care. That's, again, that's part of the bigger picture. Probably that's also part of the medical cover, I suspect. So three things.
What questions? Please join me in thanking Fraser for a wonderful presentation. Thank you.
Thank you for coming to listen as well. Really appreciate it.